Now, moving on to one of the very important syndromes called as the compartment syndrome. We'll be briefly discussing the fractures of arm and leg and how the signs and symptoms of compartment syndrome present with how to diagnose compartment syndrome and what is its management. So compartment syndrome is usually associated with either, for example, with the tibia fracture or with the radius ulna fractures. Why? Because these are the areas where there's already a muscle is present and there is not enough space for the hematoma to expand. So there's already a closed compartment which has resulted in there's an insult as well over there in form of a fracture. There will be blood and hematoma over there, and there will definitely the trauma would have affected some amount of soft tissue, which is the muscles and all the ligaments and are present around that. And there's usually closed compartment. Why? Because there is a myofascial flaps which are present between the different muscle layers, and they do not allow actually to expand beyond a certain point. So it's already limited space. Now with the intrusion of soft tissue damage, there would be edema, there's definitely increased process of inflammation over there. There's already a fracture and hematoma is present in that. Therefore the intracompartmental pressure would rise and start affecting a space which is already have a limited capacity to expand. So this gives rise to basically severe ischemia, bleeding, edema, inflammation, and increased pressure within the osteophysical compartments, and eventually muscle ischemia, which further induces edema, and then this whole vicious cycle actually starts in. And this once this sets in, because there is limited space, it can expand but a little bit and cannot expand unlimitedly. Therefore, once the hematoma and inflammation sets in, this vicious cycle is started, eventually leading to gangrene or severe compromise of the vascular supply. So what are its clinical features? Usually it's classically called as 6 P's or the 5 P's, some say it, but actually mostly it's commonly 5 or 6 P's. The foremost is the pain. And why? It's not just the pain, it's the pain out of proportion. For example, patient had a simple, let's suppose there was a fracture, a transverse fracture of the distal tibia. There's a closed fracture, and this is probably due to low energy trauma. Patient had a fall. But if you are asking the patient to move his ankle or you to hold up his or her foot and a dorsiflex or plantarflex the ankle, then this results in severe pain. This pain out of proportion is a classical sign that there is a developing compartment syndrome over there. Then this is pain with passive movement as well. There's pain out of proportion and pain with the passive movement. These are the two clinical signs which actually results that this is probably either the developing compartment syndrome or compartment syndrome has developed. Other causes which are also present with the compartment syndrome, but they're usually late causes. And once they start to appear, probably it's already too late to actually intervene, and the damage is actually already been done. So we have, for a diagnosis clinically and to pick it up early, we need to rely on the pain, and that is pain out of proportion and pain on passive movement. Other causes such as paresthesias, pallor, paralysis, and pulselessness, they are present, but they usually appear late. And once they appear, probably the lot of damage has already been done by that time. Now coming to the treatment. Treatment is the first and foremost starts with picking up the compartment syndrome. Whenever there is actually a fracture, you must keep it in your mind that there could be associated developing compartment syndrome, especially if there is swelling. If the patient the pain is not settling down despite simple painkillers, and you have splintered the fracture, there's a lot of swelling, and the patient's pain is not settling down, then your brain needs to know that there could be somewhere underlying, there could be a developing compartment syndrome. So there may be a threatened compartment decompression. There could be in form of the cast or splintage may be done, may be tight as well. And this could also be leading to, because there is swelling already over there, it's trying to expand, and there is splint from outside compressing it. So the first and foremost is just remove these cast and bandages and dressings so that you can allow the leg to swell up or expand, because then it actually results in that by ossifical, there will be some amount of osteophysical expansion, which can be it can be given a chance to expand, so that it will be decrease in the intracompartmental pressure. Then is called the value of a delta P. Now delta P is basically the pressure difference. There is intracompartmental pressures can be measured in form of special gadgets which are available nowadays. We can measure the intracompartmental pressure. For example, one option is if it's going more than 30 millimeter of mercury, then you go for a surgery. The other is you measure the patient's diastolic blood pressure, and if the difference between the diastolic and the intracompartmental pressure is, once it goes beyond less than 30, the pressure difference is less than 30, that is probably the time you operate. And instead that is the point where you go for an intervention, because probably now this compartment syndrome pressure has increased so much that it can start damaging the muscle, and myonecrosis may set in. The option to treat is basically you need to first first and foremost to be on the lookout for the compartment syndrome. As soon as it develops, first is they remove the extra splints and bandages. Then you measure the compartment pressure and measure the delta P. If you think it's going towards the compartment syndrome, then is the fasciotomy. It releases the skin fascia so that the osteophysical compartments can expand, and this fascia is actually subcutaneous fascia is released. Then the option is debridement can be carried out, because if it's an open injury, usually rarely compartment syndrome develops in. But if inside the compartment syndrome has developed, there may be a myonecrosis, and this myonecrosis, if left over there, will further result in inflammation and further myonecrosis and increased compartment pressure. So if it's present there, that can be removed as well. Wounds, if there may be a massive trauma, there may be wounds present over there somewhere as well, and the fracture may be closed. For example, if there is a shaft of tibia fracture but there are wounds on the foot and ankle, then they can be washed and wound, and then can be skin grafted as well at times. Now coming to the other early complications. These include hemarthrosis, infection, gas gangrene, fracture blisters, and plaster pressure sores. Now, as I told you, if it's around the knee, this can be, for example, there was a floating knee problem. Patient had a supracondylar femur fracture as well as proximal tibial fracture as well. In this kind of a scenario, there may be a hemarthrosis which may be going into the joint, but later on may produce complications. Or infection, if it is an open injury, or if it's a gas gangrene, especially a patient had a farm area injury, a patient fell over there where there was a lot of grass and mud and farm area, then probably the patient can develop these kind of a gas gangrene, because there is usually anaerobic environment present over there. Others include fracture blisters. If you can see it over here, they may be due to superficial abrasions as well, or if we applied the plasters for a conservative treatment, that can lead to plaster pressure sores. This may be due to the wrong application, or use too much compression of the plaster at certain area, or the patient was immobilized for, let's say, 4 to 6 weeks for any reason. There was associated head injury as well, there may be associated problems as well. This may eventually lead to pressure sores, especially over the calcaneum, sacrum, and over the occiput. In this section, we have briefly discussed what is compartment syndrome, and we have discussed the mainly signs and symptoms. The two most clinical entities are actually pain out of motion and pain with the passive movements. And this is what usually clinically determines the compartment syndrome. Others such as paresthesias, pulselessness, and pallor, which may be seen but is usually seen in advanced stages. The most important is to be on the lookout for compartment syndrome, measure delta P. Once you start suspecting that the pressure may be rising and the patient may be in developing compartment syndrome, the first and foremost procedure is to do for a fasciotomy so that compartment syndrome can be prevented. Thank you very much. Keep watching sqadia.com.